when we put together the music playlists for our trials at NYU with psilocybin, we'd all get together, the whole team. We'd order Indian food. We'd sit around and listen to different tracks. It was on CDs because actually that's that's what we all had at the time. It was back in the aughts, and it was so much fun to listen to music. And the thing about music is, even though I'm not an ethnomusicologist and I have no background, and my other team members were psychiatrists and psychotherapists, um, everybody has something to offer or wants to offer something. And we would get into some incredible fights about what's the right track here. Should this be at the beginning, or is this sort of a more of a peak 3 hours in experience, or is this something that you do in the sort of afterglow 5 to 6 hours in? Like, where are we putting this? What's evocative? The field has moved toward playlists on things like Spotify. Um, very few therapists are both able clinicians and able musicians to be able to play music for multiple hours in a row, although live music is not unheard of. Um, we use in our trials with using Embark psychotherapy at Cybin, we offer to our facilitators a few pre-selected playlists that we think are strong and good, and we've worked with a team to develop them. I also, though, think it's important not to just force people to have the playlist that you think is best. I think that when clinicians and facilitators want to bring in their own playlists, we allow for a review process so that they feel like they have ownership over what's happening in the clinic, that they're not being consigned to a particular way to work, and that we can review a proposed playlist and incorporate that into the work. So some research sponsors like MAPS allow for multiple different types of playlists, and some say you have to have one. There's different theories as to which approach is better. Some people, like Dr. Elias Dakwar at Columbia, who does ketamine research and other forms of research, prefers silence and encourages more of a meditative or mindful approach, and that a lot can emerge in silence, and that trying to overly shape the experience for patients with music is a very intense intervention. It may actually not be beneficial for all people.
Yeah.
Sometimes patients do not like a track and they ask to skip it. And I think if they really don't like a track, we can do all the dynamic exploration later as to what was coming up for you. But if they really don't like something, I encourage our facilitators to just skip the track and you can talk about it later, rather than forcing something to happen that might not be helpful. Work on this. I'll just point to two other things. Mendel Kalin's done some great work with this. There's a movement towards continuously playing sort of machine AI generated playlists. There's also a return to analog music in the room. There's a return to a movement away from equal temperament tuning to tuning in that particular key. Alexandre Tounous has done a lot of fantastic work talking about that. Like, tune the instrument to the key of A, not have equal temperament between each of the pitches, so that it aligns with the natural harmonics of 1, 5, 4, 3, the way in which when you strike a bell, you have natural harmonics that emerge that actually create the scale that you're working in. And then lastly, I'll say that, Hopkins had like a fairly and Bill Richards provided training to me. I have a lot of respect for him, but has a very Western classical music tradition. And there was a criticism that the Western classical music tradition is like one tradition, but it's not the end all be all of psychedelic playlists. And so at NYU, we had like a world music tradition, but the rule was there could be no English language. We had predominantly English speaking participants. And there's recently been a study comparing Western classical music to drone tones, like drone music, for example, bells and harmoniums and things like that. And there seems to be some evidence that the drone music may actually evoke a better response for people overall than the Western classical music, although some people really respond well to sort of traditional Western canonical music. All of this is to be saying that I'm not an expert on indigenous music traditions and world music, which is vast and rich traditions of Icarus in Peruvian medicine. There's a huge, huge body of work and deep lineages of wisdom there that I think that we're just beginning to even know about, much less understand. this is how talk therapy works, which is you don't say the same things to the person no
Gotcha.
matter what they're doing. When they're doing something, you respond in live moment to that particular person. This is a patient-centered approach. And so the idea that track number 16 is the next track that should come up is you have no idea what's actually going on in the room in that moment. So, I think that there's probably a lot of progress we could make on having more patient-centered approaches to what's actually happening for that person in that moment. And as a psychologist, we don't receive any training in music at all, right? So all of us are, except for those who have training, amateurs here and students really. And so I consider myself a student, and I'm eager to learn from people who have
Yeah.
vast training that exceeds certainly my own ken here.